What is a SAB? Staphylococcus aureus is an organism commonly found on the surface of the skin. Infection can occur when the skin is broken through surgery, injury, or insertion of an invasive device such as a peripheral vascular catheter, a PVC. This allows the bacteria to enter the bloodstream, causing several complications such as osteomyelitis and endocarditis. % of patients who develop a Staphylococcus aureus bacteremia, a SAB, will die. Device-related SABs are preventable and we need your help. How do we prevent SABs? 30% of patients that come into hospital will have a PVC inserted for the administration of intravenous therapies. It is important that aseptic technique is carried out to ensure the risk of infection is minimised. Prior to insertion, hands should be decontaminated and the patient's skin cleansed with chlorhexidine and isopropyl alcohol wipe for a minimum of 15 seconds to remove any skin contaminants and allowed to dry. Gloves and an apron should be worn when inserting a PVC to prevent contamination and to protect the staff member. Following insertion, a transparent semi-permeable dressing should be used to allow easy inspection. A PVC care plan must be completed by the person who inserts the PVC, and this will be checked daily to observe for any signs of infection, for example, pain, redness or swelling. A PVC can remain in situ for up to 72 hours, but should be removed after 24 hours if no longer required. If a PVC requires to remain in place for longer than 72 hours, this must be assessed by medical staff and an appropriate rationale clearly documented. When the PVC is in use, the hub should be scrubbed for 15 to 30 seconds using a chlorhexidine and isopropyl alcohol wipe and allowed to dry. The PVC should not be disconnected during administration of intravenous therapies. Patients should be provided with an information leaflet. This is Jane. Jane was admitted to hospital after having a fall at home. Doctors investigated and found that Jane had urinary sepsis. She had a PVC inserted for IV antibiotics. No care plan was completed and no daily checks were carried out. No one knew when it was inserted. During a ward round, the doctor noticed her PVC looked red and Jane was complaining of pain. The nurse removed the PVC and marked the area with a pen. Jane was pyrexia, tachycardic, and had a reduced GCS. Her CRP was rising too, and she was becoming more unwell. Jane was deteriorating, and blood cultures were taken. She was admitted to medical high dependency unit with sepsis. At this point, her PVC site looked very erythematous, spreading above the point where the nurse had marked it. Blood cultures confirmed a methicillin-sensitive Staphylococcus aureus bacteremia. Jane received 2 weeks of IV flucloxacillin and subsequently her arm improved. After a patient gets a SAB, an investigation is carried out to determine the source. This investigation highlighted the PVC as the source of the SAB, and an audit was carried out in the ward where the SAB was attributed to. Documentation surrounding PVCs was poor, and no care plans in place, limited medical and nursing documentation. Jane was admitted to hospital with urinary sepsis. While in hospital, she was subjected to poor PVC care and management and developed an entirely preventable hospital-acquired infection. This is unacceptable. Thanks to illustrator Gavin Porter and NHS Glasgow and Clyde Video Production Unit.